In this video, I'm going to discuss with you the single most effective medicine that I've ever used to treat multiple sclerosis. If you'd like to hear more, don't turn away, because all of that starts right now. Howdy! Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between clinic visits, and it's my hope that through these videos, I can help you learn too. Today, I want to discuss the single most effective medicine that I've ever used in clinical practice when treating relapsing multiple sclerosis. It's a heavy-hitting medicine, and it's also very complicated with lots of side effects and risk. Over the past several years, it's fallen out of favor with many MS neurologists, much to my chagrin. What am I talking about? Alemtuzumab, codename for Lemtrada. Let's jump in. I'd like to start our discussion simply reviewing what is Lemtrada, how does it work, what does the efficacy data show, what are the concerns and risks. And then, if you stick around towards the end of the video, I'm going to share with you my opinions on the landscape of MS, why the drug's fallen out of favor, and why I think that's the wrong move. So let's get started. Lemtrada is a really weird medicine for several reasons. The first thing I want to point out is that it's discontinuous. So most medicines that we take for any condition are continuous medicines. So I have high cholesterol, thanks mom and dad, and I take a cholesterol pill every single day. Why? Because if I were to stop taking a cholesterol pill, my risk of stroke and heart attack goes up. So that's an example of a continuous medicine. Most of the medicines that we use in MS are continuous. You take a pill once a day. You take a pill twice a day. You take a shot once a week. You take an infusion once a month. You receive an infusion every 6 months. And you continue those medicines forever until we can cure the disease or find a better treatment. But there are some medicines that are discontinuous. You don't do them forever. You do them for a set period of time. And in the setting of multiple sclerosis, there's a few. Lemtrada, alemtuzumab, is a discontinuous medicine. It's an infusion that you receive in the vein, and you get it for 5 days in a row. So you're infused Monday, Tuesday, Wednesday, Thursday, Friday, and then you're done for the entire year. A year later, you repeat that process, but only 3 days. Monday, Tuesday, Wednesday, let's say. And then you're done being treated with any more Lemtrada unless we see new disease activity down the line. So obviously that's super weird, and it's unusual to take a medicine in that fashion. I want to spend some time explaining how you could take a medicine 5 days one year, 3 days the next year, and then you're done. Lemtrada is a monoclonal antibody. So what's a monoclonal antibody? It's a biologically engineered key. So think about like the key to your front door. If I take the key to my front door and stick it in, it will open my front door every time I use it. But if I were to try to open my neighbor's front door, it's not going to fit because the key is very specific for that door. When you infuse Lemtrada into your arm, it's a monoclonal antibody that is looking for a very specific target. And that target are adult B and T cells. When it identifies these adult B and T cells, it knocks them out of play. But it can't see any of the other cells of the body. So it's not going to have an impact on other cells because it can't see them. Now, when it knocks down the adult B and T cells, it causes the immune system to essentially do a reboot. So some fancy pants people will call Lemtrada immune reconstitution therapy. I think of it as an immune reset because of what it does to those cells. So to talk about that for a few minutes, we're talking about the adult B and T cells. That's the adaptive immune system. And unfortunately, in the setting of multiple sclerosis, an autoimmune condition, those adult B and T cells misbehave. MS patients tend to have too many inflammatory B and T cells that are out there brawling and misbehaving. And there's a paucity, there's not enough of the regulatory cells, the police officers that are telling everyone to calm down and not get into trouble. Also, in the MS patient, there are memory cells that remember the brain and remember the spinal cord as a foreign invader. And that's not what you want to have happen. When you take Lemtrada, alemtuzumab, this monoclonal antibody, you knock down those cells and they don't come back the same. Interestingly, the regulatory cells return more robust. So now there's more cops and they're more active. And so they're better able to kind of patrol and keep everything calm. The inflammatory cells are knocked down and they don't fully come back. And so after Lemtrada, you have less pro-inflammatory B and T cells. And very importantly, you change immunologic memory. So the memory cells that misremember brain and spinal cord as a foreign invader are knocked down and they don't fully come back. So when you think about it in this manner, you start to understand how you can have a medicine which is discontinuous. It's not given all the time because it's rebooting your immune system. It's changing the way your immune system works. And as a result, we can see a long-term benefit in the absence of retreatment. When I explain this to families, I oftentimes will use the analogy of how I trained my dog River. So when River was a puppy, she thought it was all the rage to jump up on the couch, which I didn't like. So every time she got on the couch, I would snap her chain, no, and I'd pull her off the couch. And if she did it again, no, and I'd pull her off the couch. Every single time River jumped up on the couch, she was reprimanded. And she learned really quickly that getting on the couch was not awesome, that it was going to get her in trouble, and she was better off not to get on the couch. Now, subsequent to that, after she learned, she didn't get on the couch anymore. I like to point out, I didn't shoot my dog, I didn't burn my couch down, I didn't build a moat around the couch or put up a wall in my living room. I taught my dog not to do that. And after I taught her to do that, she doesn't do it. Almost ever. Every once in a while, she'll jump on the couch, and then I just need to give a quick reminder, no, get off the couch. And then she's good for many, many more months or years. Now, the human immune system is not a dog, but I think the analogy is fair because what we're doing here with Lemtrada, we're not constantly suppressing cells. We're not blocking cells. We're rebooting the way that they work. Simply put, Lemtrada is super effective. I find it to be the most effective MS medicine that I've ever used in clinical practice. I could spend a lot of time talking about nerdy things, the specifics, but just to summarize, it's super good at decreasing relapses or preventing new relapses. It's also super good at preventing new MRI lesions in the brain and spinal cord, which is awesome. It does an outstanding job of slowing disability progression. And there's even been some recent papers suggesting that it can successfully slow the onset of secondary progressive MS, which is great to know. One of my favorite things about Lemtrada is it's really good at slowing the accelerated brain shrinkage or brain volume loss with MS. And in fact, it can normalize the rates of brain atrophy, which is very impressive. One of the ways that I like to think about this is the long-term effects of Lemtrada. When we look at the clinical trials, those were called the CARE-MS1 and CARE-MS2 trials, and I was a participant in those trials. We gave people Lemtrada for 5 days, wait a year, 3 days, and then we followed them. And if they had a new MS attack or 2 new spots on their MRI, they were eligible for another treatment, so a 3rd course or 4th course of Lemtrada, what have you. And if we look across 10 years, I think the data is really striking. About 55% of patients never got redosed. So they had treatment, the 5 and then 3, and then they went for years and years and never had anything else because they never had any new attacks or new spots. About 30% of patients in the trial required a 3rd course of Lemtrada, meaning at some point they had disease activity and they re-upped and got 3 more days. And about 14% required a 4th course. So I'm not sitting here telling you that this stuff is magic and it cures MS because it's not, but I am telling you that's really, really remarkable that someone could receive 8 infusions and then have a pretty darn good chance of not having disease activity going about almost a decade. Real quick before we go on, if this video has provided you with some useful information, do me a favor and give me a thumbs up. Also, if you haven't yet subscribed to the channel, please consider doing so. Those 2 actions teach the YouTube algorithm that you like this content and then help push it out so more people impacted by MS can benefit. Thank you. Now, whereas Lemtrada is a highly, highly effective medicine, it's also super complex and it probably has more risks than any of the other MS medicines. And so I absolutely want to go through that with you. In my mind, there's 4 categories of risk when we're thinking about using Lemtrada. The first one are infusion reactions. So when you infuse Lemtrada in the arm, your immune system is not super happy, and you can have lots of infusion reactions. What are we talking about? Red rash, itchy throat, joint aches. About half of people get really significant headaches. And it can be hard to get through those infusions. Now, at the Boster Center for MS, we infuse a lot of Lemtrada, and I feel like my nurses are rock stars at giving it, but that doesn't mean that it's not a difficult infusion. When you look through all the cases of Lemtrada, there's been 13 strokes which have occurred during infusion. That's very serious. And I was an author in one of the papers that explored this, and it's my perspective that those strokes were largely caused by poorly controlled blood pressure. Now, I'm delighted that since the world has been more attentive to blood pressure during infusions, we haven't seen this, but it absolutely is a risk, and I always want to share that with families. So the first risk of the 4 are infusion reactions. We try to mitigate that by giving special medicines, so we give pre-medications before we give the Lemtrada. And this is done in other infused medicines with MS, and I find it to be very, very helpful. We also have learned some lotions and potions that we can do to help mitigate that. For example, after the infusions are over, I like to give people what I call a Medrol dose pack, which is a small taper of steroids, which seems to kind of help. The second category of risk is that Lemtrada can cause autoimmunity. You're like, what? So MS is an autoimmune condition, and when you receive Lemtrada, there's a chance that it could trigger another autoimmune condition. There's a 41% chance, which is a really large number, of causing autoimmune thyroid disease, and that can make the thyroid go up or go down. Now, it's not necessarily permanent, and frankly, it's pretty easy to manage thyroid, but that doesn't make it okay. And I have endocrinology colleagues that I adore, and they have been working with me for many years, so when my Lemtrada-treated patient develops something like that, I can send them over to the endocrinologist and they knock it out of the park. The other autoimmunity is less likely, but I'm still going to go through it with you. There's a 2% chance of something called ITP, immune thrombocytopenia. Now, I don't make up these silly words, but that's doctor talk for the platelets that clot your blood don't work. And so you can have a situation if you have ITP where you get bruised and your whole arm gets bruised up, or you cut yourself shaving and it won't stop. The very first case of this, which happened in the phase 2 clinical trials, we didn't know that was a risk. A gentleman was having bleeding, but he didn't tell anyone, and he died from a brain bleed, which is god-awful. Now, fortunately, that's never happened ever since because we have a really good program to catch the platelet count if it goes down. And it turns out that it's pretty easy to treat. We can generally give steroids or other medicines and pop it back up. And if you have ITP from Lemtrada, it normally doesn't come back. It's not a chronic condition. Now, there's a 2% risk of that. And nonetheless, we monitor for it very carefully, understandably so. There is a 0.3% risk, so that's a third of a percent risk of autoimmune kidney disease. And we also screen and look for autoimmune liver disease. And so that's part of this process. Now, in a little bit, I'll talk to you about the monitoring program, which I think is very successful for catching these so that you can jump on them and treat them ASAP. The third category of risk is infection. And so anytime you take an immunosuppressant medicine, anytime you take a medicine which does something to lower the immune system, whether that be permanently or for a short period of time, you increase the risk of infection. And this has never been more relevant than during the now. I make this video in 2023, and we're still dealing with a global viral pandemic. And so increasing someone's risk for infection is not done lightly. Now, one of the things that I want to point out is that when you give someone Lemtrada, you're not destroying their entire immune system. You don't affect the innate immune system, so that's still working. And you don't affect all of the adaptive immune system. You temporarily knock down the B and T cells, those lymphocytes, and then they come back up. And it's a period of time. When you knock the cells down, the B cells start to come back at around 6 months, and then the T cells kind of trickle in between 9 and 12 months. And you can follow the return of those cells by checking a blood count. And so we can say with great accuracy when the person is still in an immunosuppressed state, and as they transition, they get better and better. We can see that with the laboratories. During a pandemic, I continue to give certain patients Lemtrada. Why? Because it's what we needed to do to control their disease. I don't think that the fact that Lemtrada can increase infection is a deal breaker, but I do think that it takes a very careful hand to make sure that you can monitor successfully. Now, there's 2 particular infections that we think about with Lemtrada. One of them is shingles or herpetic outbreaks like chickenpox type stuff. And we want to check labs to make sure that the human has immunity to varicella. And if they don't, then we give them a shot to immunize them prior to starting Lemtrada. Also, I place my patients on a medicine called acyclovir or a medicine called valcyclovir, which protects them against having shingles or herpetic outbreaks. And I will oftentimes keep them on those medicines for several years to prevent concerns. The second infection risk that we worry about is something called listeria, which is like food poisoning. And if you leave out some smelly French cheese and then you eat it a couple days later, it might have developed listeria. and that can make you really sick. But if you eat that cheese and you have been exposed to Lemtrada, then you could get a listeria meningitis, which is very, very serious. And so we teach patients to use what I call a pregnancy diet, where you avoid unpasteurized cheeses, uncooked meats, and unwashed fruits and vegetables. Now, for some people who love sushi, they really don't like that recommendation, but we want to wait until their cell counts go back up before they're eating that raw fish. Now, what about COVID-19 infection? So I have given patients Lemtrada during the pandemic, and I've had a couple patients that then subsequently got COVID, which at first blush is pretty scary. Now, interestingly, those patients fared very, very well. Now, I'm not making this video telling you that there's no risk, because there absolutely is. I'm just delighted that my patients fared well. And fortunately, now we can make sure that people are immunized against COVID-19 before they take Lemtrada. And God forbid if they contract COVID-19, we can use medicines like Paxlovid to hasten their recovery. Do I think there's no risk? No, I'm not saying that, but I think it's a mitigatable risk. The fourth category of risk with Lemtrada is the big C, very scary word, cancer. Now, there's a 0.3% chance of thyroid cancer if you have multiple sclerosis. That's not unique to Lemtrada. In the clinical trials, we followed everyone, and we caught a couple of thyroid cancers, which were very early, and we were able to cut them out and cure them. But that's something that we all want to be aware of and monitor for. There's also a 0.3, a third of a percent chance of melanoma, skin cancer. And so before we take Lemtrada, and then once a year, I send my patients to the naked doctor. So the naked doctor gets the patient naked and looks at all their skin and writes me a letter and says, "Dear Aaron, skin looks fine, love, naked doctor." And that way we can make sure that we capture an early melanoma if we find it and cut it out. There's a 0.2% chance, so a fifth of a percent of a chance of lymphoma. And there's a way to monitor for all of this. So to share that with you, when people participate receiving Lemtrada, they have to sign up for a government program called a REMS program, Risk Evaluation Mitigation Strategy. And there are REMS programs with other MS medicines like Tysabri. So in the Lemtrada REMS programs, once a month, the person gives a vial of blood and some urine, which is used to screen for the risk of autoimmunity and the risk of infection and the risk of cancer. And they continue to get those lab tests once a month for 4 years after their last dose, which is a minimum of 5 years. Now, why don't we go beyond 5 years? Because all the risks that I just told you about have not been seen beyond 5 years. Now, I've obviously been participating in this REMS program for years now, and I can say that it's very effective at catching things early, which allows us to jump in and help out. Good stuff. So, which patient is the right patient to receive Lemtrada? Well, I can give you answers and talk about, someone who has really aggressive MS, well, they should have Lemtrada, and someone who has really quiet MS, maybe they shouldn't. But that's not actually the way that I feel. I feel that the decision to take Lemtrada is truly philosophical. There are many patients that are willing to treat their MS, but they do not want to take upfront risk and complexity. And they're willing to take a continuous therapy for the rest of their life, as long as the risk benefit is in their favor. And that's completely reasonable. There are some other humans, however, that are willing to accept upfront risk and complexity in exchange for the possibility of quiet disease, a durable effect in the absence of continually taking something. And in my experience, those are rather different thought processes. Someone will either show me their hand and say, "God, Aaron, don't talk about Lemtrada," or they lean in and they're like, "Wow, I really think I want to do that." And I find as I talk to families that people can find themselves going one way or the other. So the person in whom I want to discuss Lemtrada is someone who understands the upfront risk, the upfront complexity, and is willing to accept that in exchange for a chance at having quiet disease for years to come in the absence of retreatment. Lemtrada was FDA approved here in the US in around 2016, and now it's 2023. And in my experience, it's kind of fallen out of favor amongst many of the MS neurologists. And I think that's a travesty. It really makes me sad because I think they're not taking advantage of the single most effective drug available. So why is that? I think it's that way because the risk and complexity is rather significant. And I think that it scares a lot of MS neurologists. Now, I'm not saying that they're wimps and they're wrong, because they have to make the right decision with the families that they take care of, but it does make me really sad that they're not maybe more willing to consider it because it's so effective. I spent a lot of time on this channel talking about treatment philosophy, And any of you that have followed me for a while know that I do not think the escalation model is a good way of treating MS. I do not think it's a good idea to start people off on low efficacy medicines and then only upgrade if they do worse. And so you can check out some videos. I'll throw a card up here to one of those videos if you want to hear more about that. It's my strong opinion that a much better way of treating MS is to hit it really hard in the face up front, either by starting a highly effective medicine out of the get-go, or starting induction therapy, like kicking things off using a medicine like Lemtrada. Now, the labels don't allow us to use Lemtrada first line very often, but you could use it if the person has broken through a couple medicines. And so, in my opinion, the earlier we use Lemtrada, the more effective it can be. It is sad to me that more neurologists have not embraced using this highly effective medicine. Yes, there's a lot of risk and complexity, no question about it, but those are manageable risks. And I think with an understanding patient, this shared decision to take Lemtrada can really be transformative and help that person in a really big way. Now, why use Lemtrada when you could do a stem cell transplant? That's a question that I hear about a lot. And it's a really interesting discussion because I think people think stem cell transplants are super sexy and magical. Like you go in and swap out your bone marrow and then the MS isn't there anymore. Now, I just made a video about stem cell transplantation in MS. And just to summarize super duper quickly, I don't think that it's prime time just yet. And the risks of a stem cell transplant are more severe. They're more intense than Lemtrada. I think the risks of Lemtrada are less and they're mitigatable. And so I still firmly believe that Lemtrada is more appropriate to be used in multiple sclerosis than stem cell transplants as I make this video in 2023. I also want to point out that you can't just go down to the corner store and get either of these medicines. But you can receive Lemtrada in an outpatient infusion clinic, and you can monitor a patient who's in the community. A stem cell transplant is much more intense and involves much higher risk with the need for hospitalization and several other things. And so I think that the availability of this highly effective therapy is easier to reach than stem cell transplantation. So does that mean that I put all of my patients on Lemtrada? No, absolutely not. But I'm not scared to use it in the right patient. And in my own clinical practice, we have continued to use Lemtrada in appropriate patients with great success, and I'm going to continue to do that. I really wish that MS neurologists would reconsider the use of Lemtrada because I think it's underutilized. And I'd be very curious what you think. Do me a favor and leave a comment down in the section below, and I look forward to reading it. And hopefully we can start a discussion about Lemtrada in MS here in 2023. My name's Aaron Boster, and as always, thank you for learning about MS with me. If you would like to support this channel, the best thing that you could do is to watch another video. So click the video that's on your screen right now. And until my next video or live stream, this is Aaron Boster saying be safe and take care.